I was reading the depth of invasion, sir. Actually, there are two definitions which are given, sir. Sir, one which is given as per the recent Delhi and as per the guidelines also, sir. So that it is the distance from the basement membrane till the lowest membrane of tumor limit, sir. But sir, in some studies, sir, like MSKCC and some studies, they had suggested that it is from the reconstructed mucosal surface to the tumor lower. So I was wondering, sir, what it was.
Please repeat the question.
Depth of invasion, sir, I was wondering, sir, what is the actual definition? Because in New Delhi and as per the guidelines, it is mentioned that it starts from the basement membrane till the lowest limit of the tumor, sir. But sir, some studies, individual studies have suggested that DOI be measured from the mucosal surface to the lower limit of the tumor, sir. I was wondering what is the correct answer.
So what is the difference between the two?
So one is from the mucosa to the tumor limit and one is from basement membrane. So they're asking from the reconstructed mucosal surface, like from the epithelial line.
It can't be, because reconstructed surface would vary. It has to be from the mucous membrane down.
From the
So as per AJCC, it is the adjacent normal mucosa which is there. From that base
New
membrane
Delhi
will
actually,
come.
and also checked.
See, the AJCC has
So
defined
there are two
it.
terms, tumor thickness and depth of invasion.
invasion.
Tumor
Tumor-
thickness is the whole of the thickness from the top
Top
of the tumor
to the
till
below the
it is
tumor.
the basement membrane till what it is reaching. So it becomes tumor thickness. But the depth of invasion, which is of oncological
See, the
significance,
oncological
is
significance DOI, which you use for staging,
Yes, sir.
but less than 5 millimeter, 5 to 10 millimeters.
Less than 5 to 10 and more than 10.
You know. So if you are using So, all this is primarily based on distance from where? Basement membrane?
Adjacent normal.
From basement membrane down.
Yes,
Yes.
This is what the AJCC 8th edition is saying.
Yes, sir.
That is one. Secondly, the question relating to the oncological significance of DOI is what we should be concerned about. No. The oncological significance is related to depth in terms of penetration involving the lymphatics.
AJCC is
It is there on NCCN के उसमें भी मिल जाएगा तुम्हें ये रहा ना.
So this one is DOI, the blue one, and this is the tumor thickness from adjacent normal mucosa.
What is reconstructed basement membrane? It is the theoretical line drawn from the basement membrane of adjacent normal mucosa, which is here. The deepest point of the tumor is here, and this distance is depth of invasion. This is in case of an exophytic growth. If it was an ulcerative lesion, then the reconstructed basement membrane is this. From here till the deepest point of the tumor, which is this, the line drawn indicates the depth of invasion. This is different from the tumor thickness. In case of an exophytic growth, the depth of invasion will be less than tumor thickness. However, in case of an ulcerative lesion, the depth of invasion will be more than the tumor thickness.
Up now, why have they changed it in AJCC 8th edition? The two things that have changed are, one is depth of invasion, the other is extranodal extension. Now, why have they become wiser?
So with increasing depth of invasion, the disease becomes more aggressive in case.
With increasing depth of invasion, there is more chance of lymphatic spread. And the
Lymphatic
distant
nodal
It's totally related to whether the tumor has hit the lymphatics. And the single most important predictor of outcome in head and neck cancer especially was the presence of a node metastasis. That was the past thing. Node metastasis, if it is present, the survival drops by 50%. How much?
50%.
How much?
50%.
So if X had no node cancer, the other one Y has cancer with nodes, this one and this one, 50% difference. Then they looked at the nodes. Sometimes the disease remains confined to the node and you remove the node, the disease has gone and blocked. Again you would argue if it is a regional node or a far off node. I am telling you the controversies that come. If you are removing a level 1 node in a lower gingivobuccal sulcus cancer, it's almost there. Versus a level 5 involvement, it is traveled. The echelon has changed.
Yes, sir.
But they were initially grouped as one only. So then they got wiser. Is it the node? And then they asked the pathologist, as always, what do we do? The pathologist, if you have read final diagnosis, pathologist is the final diagnosis, no? Right? You read the book?
Little.
Arthur Haley.
Yes, sir. Little.
Read those books. Don't read all this WhatsApp stuff. Arthur Haley की book है.
Yes, sir.
Final diagnosis. The name of the pathologist is Pearson, who gives the final diagnosis on a bone tumor amputation. It's a very interesting study. So final diagnosis comes from the pathologist, whether to a living person or in a autopsy. That's why, what is ATNM?
Autopsy.
Autopsy ATNM. CTNM clinical.
Clinical.
PTNM pathological. RTNM recurrent. Should know all this. Coming to the reason why they thought of extranodal extension was it is of relevance only when it goes out of the node. Because what are we looking at? What is going to kill? Not the node. Distant metastasis. And the usual echelons that it traverses is from the tumor to the lymph node to the veins, and veins to the system. So now it is not just the tumor. T was earlier just the T.
Yes.
It could be wide or varicose, no invasion. So they thought depth of invasion is what decides because varicose used to have a good outcome.
Yes, sir.
Why? Because there are no lymph node metastasis. Varicose means just growing outwards.
Growing out.
It is also infiltrating. Where is it infiltrating?
Vascular.
Into the air. It is invading, but invading the air, which doesn't bother you. So, like, the flower, the petals will keep dropping off, it will keep on. So that was varicose. So varicose was good news, not bad. Warty. But if it goes in, it goes to lymph nodes and then that channel starts. So they decided to have DOI included in the staging, less than 5 millimeter, 5 to 10, more than 10 millimeters. That is T1, T2, T3. T4 has nothing to do with the size. T4 is usually to do with the adjoining structure involvement, like in this breast cancer. Up to T3 it's size.